homeostasis. And I have been emphasizing it time and again that it's not temperature, it's not blood sugar, it's not calcium, it is the osmolality which the body is most significantly wanting to keep in control. And this osmolar regulation is central. Because if you see glucose levels between 70 to maybe 150, 160, we're not doing anything. There's a huge range. You have a comfort margin. Calcium, maybe less than 8 and more than 12, you start working 1.5 times. But in osmolality, a single % difference triggers a homeostatic mechanism. So osmolality changes are very, very important. Why do you think that is the case? Why do you think osmolality plays a major role? Fluid and electrolyte is determining the osmolality. So osmolality is not determining your fluid and electrolyte. You're maintaining your fluid and electrolyte to ensure that you've got good osmolality. Because the brain tissue is exquisitively sensitive to small changes in volume. If your osmolality becomes more, your brain will shrink. If your osmolality becomes less, your brain will become swollen. So that is a big problem. So CNS adaptations are going to be very, very difficult. So that is why body doesn't risk a change in osmolality. So there are two things we remember. We've got the tonicity and the volume. And these two are linked with each other, but it's not that they are typically similar in that perspective. So we've got osmolality, or largely if I say osmolality, I'm talking about sodium. What are the key osmoles in the body? 3 major osmoles which are always considered. Yes. And urea pretty much crosses the membrane. So it's of minimal consequence unless somebody has got uremia. Glucose. So it's only problematic if you have diabetes. So the only osmole, and it is the most important, you say sodium is 145. So 2 into 145 becomes 290. Glucose is hardly 10, 15. So the only osmole of significance is sodium. So in a patient who doesn't have a renal problem or an insulin problem, you're mainly talking about sodium is equal to osmolarity. So that's why sodium regulation becomes important from that perspective. So now you've got 2 major mechanisms by which you can balance in terms of osmolarity. One is thirst and one is urine output. So if you are getting dehydrated, you drink more. If you are having too much amount of fluid, you pass the urine. So the primary method for prevention of dehydration is thirst. The primary method of prevention of fluid overload is excrete the urine. Of course, if you are having too much fluid, you will take less water. If you are having too little fluid, you will be passing less urine. But that itself is not the end story. The primary regulation when you're dehydrated is drinking, while your primary regulation there is to pass on your free water using the urine. So this is a mechanism to think of. Now we know that you've got the thirst mechanism whenever your tone becomes more. So your tonicity is going up, which means that you are getting dehydrated. So in that regard, what you want is that you want to have more water. So for that, would you like to drink more water or shut your urine first? Dr. Sandeep. Why? So if you want to save money, first of all, any advice, any investor will tell you stop wasting your money. And then you start saving, because if you save and it's lost, that becomes important. So what does this tell you about the osmotic threshold for thirst versus osmotic threshold for urine output? Yeah. So if you talk about principally, basically you want to first of all stop your urine output before you start drinking. So there is a 10 milliosmoles different. You said 283, 293 roughly is the time when you have the peak value as far as the thirst and the peak value as far as urine output regulation is concerned. So this is the mechanism. So whenever you are having dehydration or your osmolarity is going up, you would have specific organs which are working, which are the organ vasculosum lamina terminalis and subfunicular organ. And these organs are unique in their location. What is unique about their location? So the brain is surrounded by what all is there around the brain? You've got the dura mater, the pia mater, the fluid. So how does it sense the blood levels? Is it? And how are they unique? So do you think this is in the blood? And you've got the blood and the brain. In between the blood brain, you've got the blood-brain barrier. So these specific sentries, the sentinels, they are outside the blood-brain barrier in what is known as circumventricular organs. So these ones will be, in a way, put there just to sense, okay, what's your sodium? What's the level of the osmolality? And they will pick up from there. So they are outside the blood-brain barrier. So OVLT and SFO will then immediately say, okay, there is something going wrong. This person is getting dehydrated. The fluid is getting less. AVP come into the action. And AVP is going to go directly right at the level of the kidneys. And the only work AVP does is to increase the permeability of the collecting duct to water. So if you are absorbing, I'm just saying an example, maybe around 10% of urine, now you're absorbing 60% of urine. So you will have much more concentrated urine, and we can concentrate urine by how many times? 10 times in the sense, 10 times means, so if you have, let's say you can actually have 20 times. So you can have 10 liters if you are completely dilute and maybe 500 ml. That's the sort of a thing, 20 times. But when I'm talking about concentrating, I was talking about in terms of compared to the blood, the plasma, how many times we can concentrate. So what's the usual plasma osmolality? Around 300. The maximum urine will go around 1200. So you can probably go 4 times concentration, which is done. The major contributor there is, of course, AVP, but also the medullary concentration gradient, which plays an important role in that scenario. So that becomes important. So this is how your AVP, we'll talk a bit more about AVP. The second aspect here is the volume status. Now, whenever your volume is going down, that is a more dangerous scenario. But body gives you a margin, 10%. So 5-7% problem starts happening, but you will start reacting at around 7 to 10%. The first mechanism there is the renin, angiotensin, aldosterone system. So where is renin produced by? So that is the exact side. So all the sides are very, very well chosen. So brain, those organs are there outside the blood, getting their signals. In the kidney, wherever your filtration. So what are you bothered about? When you say your volume is less, what are you most bothered about? No. Volume is less where you are most concerned? In the kidneys. So if your blood flow is less, the first thing you want is that, okay, kidney should keep on working. So just there you have kept the juxtaglomerular apparatus. From there you have got the renin, which basically converts angiotensinogen into angiotensin 1, then 2, and then ACE, and we all know about that. The angiotensin 2 receptor, which is going to cause vasoconstriction, causing the afferent arteriole to constrict. The blood pressure goes up, it goes up, and then aldosterone comes into the picture. So this is how the RAS axis becomes activated to get your volume back into picture. Now, RAS axis and AVP have got a close association. Both of them are working toward the same goal. They are cousins, you can say. AVP by decreasing free water excretion and RAS by decreasing sodium excretion in net is saving you sodium and water. It is just the opposite of the atrial natriuretic factor. So that is, there is one hormone which is working against them. These two are basically, they are going to work in a way to increase your water and increase your sodium. So net amount of water will become more. Now, if your volume goes up, which part of the body will be the best to perceive and where you will be more concerned? I said if your volume is going down, kidneys are to be saved. If your volume is going to go up, which part has to do most work? Heart. So basically, if you think physiologically, Heart says, okay, I don't want to work more. I will put something to get this volume down. So what it does there is that it is going to secrete the atrial natriuretic factor or ANP. Now it basically is a natriuretic peptide. It is going to cause sodium loss. It is going to cause vasodilatation. So it's just the opposite of all these things that you talked about. So there are two big agents which are working towards conservation against deficiency of water and deficiency of sodium, while there is only one weak agent which is working towards the excess amount of fluid. Why is it?
We are more in favor of conserving.
So we have evolved in a time when the chances of losing water and losing sodium, or where you did not get access to water for a long time, access to sodium for a long time, was more likely. But in the current day of age, when you got so much water, sodium everywhere, it is the other way around. And that's why hypertension has become much more common in that perspective. So this ANP will start acting from that perspective, and it is going to counter your sodium excess. Now, if you have, let's go beyond the point, if somebody has a primary hyperaldosteronism, your aldosterone levels are high. What is the expected effect on the sodium, the potassium, the water, the blood gas?
It's split out. H plus and at the same time.
Yeah. So you will have hypernatremia, hypokalemia with metabolic alkalosis. How many patients with hyperaldosteronism have hypernatremia? So what is the major cause of hypernatremia? Natremia. Fluid deficiency. Sodium excess is not a primary cause of your hypernatremia. Neither is sodium deficiency the primary cause of hyponatremia. The primary cause of hyponatremia is too much fluid. Here you have got too less fluid. So you said that hyperaldosteronism have hypernatremia, hypokalemia, but hypernatremia is not there. Why?
Volume status will be increasing, and this volume will stress the atrium.
So ANF will counter your hypernatremia. So you will have no edema. You will have no hypernatremia. The only presentation will be hypertension with hypokalemic alkalosis. So